You're welcome. It's a good thought.
Oh, you still
I'm
no,
gonna say
I'm
something
sorry.
real quick.
Yeah.
Just a couple of announcements. We are recording today, so please be aware that there is a camera going back there. This is the last day of Where Can I Gives. Yes,
Will that be available to us?
it will. It takes me a little bit, but then it's on our YouTube channel. Yeah.
Great. But I don't have to do that because you're locked out.
Yeah, exactly. Yeah, it'll be up. So Where Can I Gives is the last day if you want to donate to either the library or the Friends of the Library. It's holiday season, so we have 4 events coming up, and I'm going to go through them really fast. Next week is a special holiday story time, if you know littles, Wednesday at 10 a.m. Thursday at 2 p.m., Polar Express up here. Doesn't have to be littles. You can come too. Thursday night, Jingle Trivia, Holiday Trivia at 6 p.m. at the Merman. And then Saturday night, our first adult story time, also at the Merman at 6? 6, yes, also at 6 o'clock. Thank you, Dr. Dutton, and we're so excited you're back.
Yeah, thanks for having me. Sort of agenda today, I'll just quick introduction of myself. I think most people know me, we've already met, but and then kind of a broad overview of how is time allocated in a visit, like what are we thinking about when we're stepping into a patient visit, and what happens before and after. The financial reality of modern primary care, which is, I mean, you guys kind of like might guess that might be what our pressure is, and why time constraints are getting more difficult to make ends meet. Optimizing your visit, the reason you came, being prepared and maximizing the face-to-face time. And you'll hear that a lot, but like that's not only a coding and billing term saying face-to-face, but it really is what it boils down to, the meaningful time spent with you and your provider, face-to-face. Looking each other in the eye, describing your problem, trying to understand the symptoms, how they're affecting how you're experiencing your life, but like how do we fix them, and kind of looking at you as the whole patient is a lot easier to do when we're face-to-face. And then we can have an open discussion after that. And I have some topics potentially for that.
Face-to-face, not over the internet.
Yes. So that definition has slid back and forth during COVID because face-to-face could have been a dangerous experience for either the provider or the patient at certain times. And so there were a lot of more lenient guidelines for face-to-face, but nowadays face-to-face is back to in-person, face-to-face, able to physically examine and see and hear the patient. Because when we talk about specifically non-in-person contact, we've got various mediums. So there's like the patient portal, which is more like an email. There's an audio visit where you're just on the phone. And then there is a video visit where you can see the person, but not still in person. So, and all those still get utilized, but they get billed differently. So the office gets paid or reimbursed differently for those, and there are requirements for certain things to happen face-to-face, and certain things that can happen non-face-to-face. So, but good question. All right. So a little bit about me. I'm from Lana, so I'm a Colorado native. I practice outpatient family medicine in Spanish Peaks. I'm also the medical director of that clinic. I'm a hospitalist, so I work in their hospital. I do I do a week on at a time where I admit and care for all the patients in the hospital 24/7 for that week. I just got off from that at 7 a.m. this morning. So little caffeine, it helps, right? And then I'm also I take care of approximately, or I'm primary care for approximately 30% of the VA patients. I also care, when I'm on call, I also care for them real time. We're the person that they call when they need something. So I pretty much post up in the hospital for that week and care for the hospital and the VA. I got my training at the University of Colorado School of Medicine for medical school. And then I did my residency at St. Joe's, which is right downtown Denver. So, and just to put it out there, a much different population than what I serve here, right? All right, so let's start out with how is time allocated. So, and there's some statistics in here. I have a lot of references, so if you guys are interested in any particular thing that I say, if there's a, if there's a bracketed number, there's a reference to that in an article that goes along with it. But so average primary care visit, this was a hard number to pin down. I've found various studies, but more consistently, I was personally surprised that it was approximately 18 minutes face-to-face. It's broken down differently in different studies. They've done a lot of interesting studies that are literally like a video watching a provider all day, and then they break that time up, but they break it up differently. Sometimes face-to-face in some of the studies was like actively engaging, looking at, talking to the patient, and if the provider looked down while they're in the visit to do this, that wasn't considered face-to-face, okay? So when you see the breakdown below, it doesn't add up exactly, but these are numbers that I can at least stand behind when I'm having a really good day. This is maybe be what it looks like, okay? Also keeping in mind, depending on the patient population, these all vary. So when your patients are over the age of 65, typically being hard of hearing is a common thing. So you're trying to speak up loud, but you're trying to enunciate, you're trying, and vice versa. They seem to bring more support with them, and they end up having more medical problems and are more engaged in their health, and as is their spouse. And so the back and forth for someone who has 5 or more medical problems plus is hard of hearing is definitely a longer visit versus 15-year-old coming in for a sports physical, right? So keep that in mind. These things vary greatly, but on average, 16.5 minutes face-to-face, not with our face in the computer, okay? And at the end, if we have time in the discussion period, I'll talk about some technologies that are really improving that situation for us and our patients. 2 minutes working in the EHR while in the room with the patient. So time that they're actually directing their eyes towards their computer, they're entering orders, they're entering referrals, they're looking things up in your chart. 7.5 minutes in non-FaceTime. And this one is probably during the allotted time that provider was given for your visit, but doing things not with you. Okay, so like documenting. And then 6.9 minutes, so about another 7 minutes. EHR work outside normal clinic hours. So this is what we call pajama time. So we're at home, our family's watching TV, we're in the back room, still plugging away. And then 2.9 minutes on pre-chart review. And that's just time spent perusing, what did we talk about last time? Going over your current medicines again, looking at your vital signs before we walk in the room, that kind of thing. Whatever data we have that's going to prepare us to just have a discussion with you at your visit. So notably, physicians spend more total time with their computer than they do with you. And this was the heartbreaking realization I had within my first 6 months of practice. Not what I signed up for. I hate computers. Like, I absolutely hate with my nose in a computer, and I do it 8 to 10 hours a day. So it's been a very difficult realization. It's getting better. AI, believe it or not, is probably going to help bridge that a little better. We can talk about that at the end, but a terrible realization for most family docs who want to, family medicine, they're all people that want to hang out and spend time just talking and fixing things. They don't want to be doing all the other stuff behind the scenes, so on a computer, mainly. So it says 1 to 2 hours of unreimbursed after-hours work daily. I would say I'm nearing that. I'm still over 2 hours a day, and that includes every single day on my days off, okay? And I'm pretty fast on the computer and do my work pretty efficiently. We have providers that have been practitioners their entire life and are still averaging 3 to 4 a day, and that's on their days off too. So it's burdensome. It is the primary cause of provider burnout. So not telling you that because I'm expecting patients to want less from providers, because unfortunately patients need more most of the time. But just saying it's a reality that we're dealing with. So the complexity challenge, go ahead.
How are you holding up?
I'm doing okay, right?
Okay.
As the medical director of the clinic, didn't see this coming either, one of my largest time sinks are talking with providers, trying to work them through efficiency and trying to decrease their burnout so they don't quit.
Thank you.
Yeah, it's intense. I would say there's never a balance struck for all my providers at once. I'm always talking with 2 or 3 people about, hey, we're getting 3 weeks behind on our notes. I noticed you didn't get this ordered because maybe you were in a hurry. and that ends up, generally there'll be some crying involved. I mean, and people, providers are human beings too. They have their own drama at home or whatever's going on. And there's very little time to be someone outside of work these days. Again, we had a big pressure taken off about a year and a half ago, thanks to AI, and I would have not been the person to up here boasting about AI, but at least this particular version of AI has been helping us, and it's something that helps us document. So that's what we spend most of our time doing, is just typing away. So, but we'll talk more in the Q&A section about like what does a provider spend their time doing then if they're not spending it talking to me, right? So.
Can I ask a quick question?
Absolutely.
What's caused, my dad was a primary physician 100 years ago, what's caused the increase in the need for documentation?
We'll get into that.
Okay.
But I will say the documentation burden is mostly reimbursement related and not reimbursement.
You're talking about insurance.
You got it. So, and there's a statistic in here, but about a third of the money involved in a lot of healthcare systems are not going to diagnostics, treatments, time with the patient, paying a physician, paying even your staff. It's just an investor or someone that manages a big plan. And so, and then pharmaceuticals have gotten kind of out of range. But that being said, when we talk about like the pressure on a provider, the systems have just keep distilling more efficiency out of our unit of the care system, which is like the clinic, so front desk, MAs, and removing the middle supports that used to do these things for providers, for instance. Now it's like, well, we have this fancy computer. Can't the provider just do that? And we can cut out another middle, So it's cutting out a lot of people that used to support physicians. So, back, sorry, you said it was your dad?
Yeah.
So back in your dad practice, or I would even say like, just go to New Zealand right now, or a country that really still values that work for the provider. The documentation burden is not anywhere near what it is here. And when I say burden, it's about like, if you aren't extremely specific about everything you do, you're not going to get paid. And for a critical access hospital like us, the way we get paid is really interesting. There's all kinds of different revenue streams going on, and they're very slow and they're very puny. And because of that, rural health clinics and critical access hospitals being designated, you do get reimbursement in other forms, because they know you can't make ends meet if a third of your patients are Medicaid and a third of your patients are Medicare, and then you've got like this 5% margin of private pay or private insurance that actually pays, and so they do reimburse, but that reimbursement is getting more difficult to obtain and getting smaller and putting more pressure on us. And I mean, and then those pressures have been going on for 5+ years heavily. And if you go to like states like Texas is probably one of them I think of that just has had massive closures of critical access hospitals, right? There's just care deserts erupting everywhere because the math doesn't math. And again, I'm very supportive of my administration. I mean, over the years there have been some struggles, no doubt, but they are doing the best on both sides for everybody, trying to keep things balanced, keep the ship afloat type of thing. So, just a quick statistic I thought was interesting. Proportion of visits addressing 3 or more problems increased from about a third to more than half. So our patient complexity is also increasing, like the amount of expectation in each visit. And this is an interesting statistic. To provide all guideline recommended preventative and chronic disease care, a primary care physician would need 27 hours a day for a typical patient panel of 2,000 to 2,500 patients. So, obviously that doesn't work out. So we don't provide the care we want to give, which brings up a topic maybe we'll have time to talk about, but moral injury. Like the doctor doesn't want to be in this situation. They want to provide quality care. They love the patients, right? But I will say for that statistic, we do not push panels that big at Spanish Peaks, which I really appreciate. There may be a day when we have to, because obviously we're the only thing from Alamosa to La Junta, Trinidad to Pueblo, and everything in between. But right now we try to keep our panels just over 1,000 if we can. That's our goal. Now that, I don't know how long, I mean, there've been times where it's fluctuated both directions because the provider will up and leave, or get fired, or, like, and so one of us will take on a whole nother patient's panel, or a whole nother provider's panel at once. But, that is very typical for a small area like us. Like,
Hasn't it helped to have the VA there in terms of flow of monies?
they're a big financial buffer for us, and always have been. Super appreciate them, right? In that we share services, so dietary, laundry, all the diagnostics. So, and then on their end, we bring in a lot of business for them because, hey, your loved one can be right next to an emergency department and wheeled downstairs if they get sick and be admitted to a hospital bed that's literally, less than 100 feet from where they reside, or, that kind of thing. But absolutely, I think our model of care is probably why we're still open. There have been a couple times since I've worked for Spanish Peaks where times were super tough, and we had to let people go, right? And I think without that buffer, maybe one of those times we would have closed. But yeah, we greatly appreciate our relationship both ways. So.
Thank you.
Mm-hmm. So the financial reality of modern primary care. So insurance complexity is one that immediately comes to mind anytime I think about this, and that creates this administrative overhead. And in my opinion, that's eroding care capacity and care quality. So two totally separate things. Capacity, our ability to see everybody and get everything done, and that's always difficult. And then the quality gets diluted. You call it a financial ecosystem, but it's not as much the clinical skill set and the difficulty of the medicine that is straining us as providers. I mean, most of the people who work in a town of this size, we have very little outside support from specialists. While we can refer people out of town, that doesn't help us in the next 6 months nowadays, right? Get a referral, it takes forever. So we're left providing some pretty intense care for our scope. But that's honestly not the main strain we face right now. It might be a pretty big word, but I stand behind it, administrative chokehold. So I mentioned earlier 15 to 30% of total U.S. healthcare spending consumed by administrative costs. I would say in my experience and kind of what I juggle as the clinic medical director, prior auths are probably our biggest burden of something time-wise. That this is time I could see getting diverted to patient care instead, face-to-face, increasing face-to-face time, if we weren't arguing for the diagnostics and medications that we think the patient needs. Any new medicine is going to generate something called a prior authorization. That means the insurance company is going to tell the patient, I'm sorry, your doctor said you needed this and we don't think you do. They probably should have prescribed something cheaper or different. Or they shouldn't have ordered that MRI. We think that really you could probably start with this, and this, and then, and so that situation happens so often that it is one of the most time-consuming processes that go on in the clinic day, real time, and for the most part, initially they hit the provider really hard. We have attempted to shift and have been pretty successful in shifting most of that time to other staff, but a lot of time these issues are so complex that a medical assistant couldn't answer the question or fight the battle. And a lot of times it does require a provider to step up and argue with, say, another doctor who works for an insurance company, the Darth Vader of the system, right? These things can really delay, slow care. Imaging's a killer one that you think someone needs an image right away and you're on your third attempt and it's taken 2 or 3 months on something that shouldn't happen the day you ordered it. So provider burnout is, like I said, as a medical director, I deal with this a lot, and it's the same. All my providers really, like, the highlight of their day is the time they spend face-to-face with their patients. And they just keep getting asked to have less and less of that, or having it cut short. And then they go home to just a bunch of meaningless paperwork. Not always meaningless, but like the way the processes have to happen makes them very burdensome and seem very administrative. Like, I didn't go to school for this type of thing, right? And I mentioned that the term moral injury again is that our providers are here to help people, not have their nose in a computer most of the time. So, and then they get to see like all this care they want to provide get cut short because nobody's willing to pay for it, mainly insurance. So that really reduces availability of our providers. It stretches them really thin. If they spend that extra time with you, they will pay for it on the back end at home, not spending time with their families, but just trying to stay caught up. For us, I'd say critical access hospitals, low and slow reimbursement. This is what our administration is always dealing with, trying to balance the books while not pushing us to the brink. And it is the conversation has always edged around, don't you think we could go down to 20-minute visits? And when I say 20-minute visits, that doesn't mean 20 minutes with the patient. So Spanish Peaks has been really, and again, I praise them on this. They have allowed us to continue at a 30-minute interval in our patients, which is not very common these days. But our argument is, if you go to a geriatric clinic, which again, I think it's like 80+% of our patients over the age of 65, a geriatrician gets 45 to an hour per patient because it takes that much time to manage that many medical problems, to get it across and do a good job. And so that margin we're always talking about that. You know, if we push the efficiency to the point where we can drop this to a 20-minute interval, so 30 minutes with your provider means, realistically, if it was an efficient visit and everything was working on the computer side and everything, we could probably spend 20 minutes face-to-face with a patient, and that's my goal. Like when I enter a patient room, I'm trying to get 20 minutes. It just depends on what happens. So if you look at some of these numbers, I would say my average complete, like open the chart, see the patient, document, order, into the next room, that's more like 35 to 40 minutes for me. So that's why I always run late. But it's not because, and it's usually that 20 minutes, I'll shoot past that with the patient, or there's care coordination on the back end, I just can't get together in that amount of time. Claim denials I just threw in there. We don't have to go over that in much detail, but just to let you know, like especially on the inpatient side, we get denied claims all the time. We can hospitalize somebody for 3 or 4 days, and the insurance company literally will be like, "Yep, we're not paying. You guys coded this wrong." And then you have this, you know, to get our money back, we have to call. And I personally had to do this, and Dr. Vajan has taken this role over for me, so I super appreciate that. But we literally have to call and talk with another physician who's arguing against the reason why we admitted the patient to the hospital. Even though an admission at Spanish Peaks requires 2 decisions, emergency department physician and the admitting physician, 2 doctors agreed on the need for admission. So that's a common time suck for a lot of us. And then the fee-for-service problem. So this system of insurance companies kind of trying to distill out what they can from it. They're using metrics that we're trying to place in there. So specific billing codes, specific diagnoses, how many diagnoses in that visit, how many medical problems does that patient have overall, how many medications are they on? And we're documenting those things to try to show that we're providing care to a complex patient and we should be reimbursed for that. That has led the system to sort of evolve to something that is more about volume and not quality, if that makes sense. And so the incentives puts incentives on the number of patient visits, but also penalizes us when the quality doesn't happen. So they have quality metrics. So when we say we're talking mainly Medicare and Medicaid, but all the other payers follow suit. So they set the bar, then everybody follows that bar, and they may say, well, Dr. Dutton, this patient's hemoglobin A1C hasn't improved in 6 months, and you're falling out on this metric, you don't get paid as much, but this hospital that we're allowing to compete with you, they're doing better than you, so they're going to get some of your money. And that happens. There's money that gets redistributed amongst hospital systems, and they decide within all the hospital systems how much money is going to get paid amongst all of them, and that money gets shifted based on your performance. So you compete against each other. So it's really interesting. rural areas get hit the most on this, because we just don't,
What you went to school for either.
no. Oh man, do we know a lot about it now?
You need
I
to
really-
unionize.
What's that?
You need to unionize.
We have organizations that at least we can commiserate, but at the end of the day, there's a lot of push, and it sounds good to be like, hey, well, let's incentivize these hospitals, and we call it pay for performance, right? We're going to pay them more if they perform good. That ends up being like, pay them less when they don't perform because they don't have the resources. And the second you hit that margin, it's a slippery slope to like, we can't make ends meet, and we're providing really crappy care or whatever, right? And we're not. I feel like we're very, care quality is super important to us, but that basically lands on the provider's emotional status.
With universal health care,
That's a massive question, right? Regardless of the healthcare system that would be successful, and I don't know that the United States can ever come up with one, I think we're just too greedy. Like there are certain things in the human existence that shouldn't really be allowed to be monetized, in my opinion. And healthcare is, I'm with, I don't want to get political, I promise, but like I'm with the old Bernie Sanders. Like I think healthcare should be our basic right, regardless of the reason why it should be basic right. Like you probably understand why I would think that, but like financially it makes more sense for a country that supports the health of its individuals because they'll be more productive in the end. It will cost the system less in the end. Like our current system is keep marginalizing people until they completely break, and when they come back into the system at that point, they're very costly. Not only it's a terrible patient experience to be a broken patient and have to re-enter the system broken and try to get fixed, but it's very costly too. And I think that's the part that I don't understand why. There's plenty of studies to show if you maintain the health of a group of people, whether it's an entire county, let's say, as a group, if they're healthier, they cost the system less. If you allow them to get unhealthy because the human body's something that takes time to recoup and sometimes doesn't and just stays unhealthy, that medical care is much more expensive. And I think we're on the brink of watching this get really expensive really quick. I think once you start making healthcare less accessible to everyone, I don't care who you are, whether you have a job or not, they still come to the emergency department, they still come to the hospital, they still come to the clinic whether they can pay or not. And in that scenario, the cost of providing care to that group goes up even higher. And then on top of it, you have a large amount of people that are extracting money from that system that aren't even involved in it. And that's, you put all that together, and again, the word misaligned comes to mind. I put that on this slide, like very misaligned goals. Because you can't align the goal of healthcare givers with making money. Like it just doesn't work. Now that being said, I'm a family medicine doc, right? I don't make a lot of money compared to my colleagues. I'm one of the lowest paid per hours worked physician there is. That's well known. Like you go to medical school, you're going to be a family doc, you're going to work hard for your money. Your hourly rate based on how many hours you actually work, how much you get paid, is not that impressive. You go to a for-profit dermatology office though, it's the exact opposite situation. Those guys, quarterly meeting, all my employees are out there, I'm the dermatologist, and I'm like, hey guys, you did great. You were seeing an average of 35 patients a day. We made over $5 million last year. That's the kind of thing that's not where I work, right? So there are situations that I feel like medicine is very for-profit. But I don't support that. Like, I went to med school with people who went into medicine to make money, but that's not common. Most people, especially if you're talking primary care, you went into it for good reasons. And to be a part of that money-making process just doesn't feel right. So, let's see. I think I kind of covered all this. The system incentivizes complexity and volume over simplicity and value, directly hindering patient access and provider well-being, and ultimately face-to-face time. So again, moral injury. That's my only way. I learned that term during COVID, and I use it a lot now. It's like not what I signed up to do, but I'm gonna keep trying. I think we kind of covered all this too. I don't want to spend too much time. I just want to get to like how do you guys actually make your visits better. Standardized appointment duration times, we're on that model, but it's not in a bad way. I feel like that's actually working to our benefit because we're saying, hey, can we at least get 30 minutes a patient? And that's like, boy, that's asking a lot. It's like, well, we'll do our best in the amount of time. And sometimes it doesn't take 30 minutes, but centralized scheduling, so there's a couple of asterisks here. Centralized scheduling is like even diluting and distilling the system even more to try and make it more efficient. We've been able to avoid that, but we might be in a position where we have to consider it based on just being able to find people to work the front desk and take the insane amount of phone calls they do a day. We may get 100 phone calls before noon at Spanish Peaks. There's 4 people at that front desk, checking people in, checking them out, answering the phone. So a lot of those phone calls end up in the voicemail, and somebody has to check that on their lunch hour, that kind of thing. So, and I also mentioned the large patient panels. We are not running patient panels of that size at least yet, which is nice. So, all right, the reason you guys came here. So, when we talk about coming into a visit and being efficient, it doesn't mean there can't be any small talk, right? Small talk's important too. You have to trust your provider. You have to connect with them in a way to share things you share, to be vulnerable during a physical exam, to trust them with the medication they might prescribe to you that has this insane, like, legal size list of side effects, that happen 1% of the time. But that's important to connect, but at the same time, being prepared. And so showing up to a wellness visit, this is the worst one, is you show up to a wellness visit because the clinic called you to schedule the wellness visit because Medicare told the clinic that they won't pay them unless you come in at least once a year and do a wellness visit. And you show up to that visit with nothing wellness related. I have these 7 complaints. They're all chronic. They've been going on a year. That approach to your visit, which happens, oh boy, like a quarter of the time right now because we're trying to catch up on these wellness visits. It just won't result in either the provider or the patient walking out of the room feeling like something meaningful was accomplished. The value will be low, okay? The visit complexity will be high, the value will be low. It will not be a simple visit. And you're really striving for a simple visit, right? One where you really hammered down on a topic that you were worried about and were doing something about. 1, 2, or 3 topics, right? But showing up, that doesn't mean don't show up with a laundry list, okay? The laundry list is helpful, right? We want to take care of that laundry list. We just need to look at it and prioritize. You might think your toenail fungus is important. We think your chest pain is more important, right? And so there's 2 competing things potentially going on, but hopefully not competing by the time we're able to talk about it and come to grips with the big picture and say, no, this chest pain actually has me very concerned. And this is why. And if you disagree with me, we're off to the races on your toenails, sure. But listen to me first, right? That being prepared means literally sitting down before your visit and putting your thoughts together on a piece of paper and then thinking about how you're going to describe the problem to the provider. You don't want to come in not really remembering anything about the problem but still worried about it. You need to think back. When did it start happening? When I was on that hike a couple months ago. Was it 5 months ago? Get in your phone and look. Did you take a picture during your hike? Like what happened that could give us some ideas of like the temporal association of the symptoms, right? So effective agenda setting at the visit's beginning is the single most important factor for productive visits, and this has been studied so much. And this is the one that I review. I don't review with patients. So this is a point I bring to the providers over and over and over. Agenda setting. Okay, stop. Decide how long you're going to small talk, and when that's done, you need to set an agenda with the patient. Why are you here? What are we talking about? This is the reason for visit that you called in about, but you're telling me 5 other different things and you haven't even mentioned the thing you called in about. Okay? So the list of concerns, prioritized. And your priority, not necessarily the provider's priority, and understand that those could be different. Okay? You may list off this priority and the provider says, well, I beg to differ. Maybe that number 3 item is actually the number 1 item. And be open to hearing that. and transitioning to that being the most important item because maybe it's a little more threatening to your life, right? Bringing your medications. You don't have to do this if you have like 1 or 2 medicines and they haven't changed in years and you've been going to the provider every 6 months and it's the same things. Most patients are not in that scenario. Most patients have more than one cook in the kitchen, right? If you have more than one cook in the kitchen, so you have a cardiologist and a neurologist and a urologist and a dermatologist, and everybody prescribes medicines, you need to bring those medicines to your visit with the bottle, right? Not in a box, because nobody knows what gabapentin 300 looks like compared to something else, right? They're all different, especially if your meds are generic. But we just don't have that kind of time. So we would run through the medication list with you. It's just one of the single most time-consuming but important parts at the beginning of the visit. If the bottles are there, like, wait, I don't think we prescribed that to you. Oh, I think you do. You pull the bottle up. No, it's your cardiologist right here. They prescribed it. It looks like they prescribed it a month ago, and we saw you 3 months ago, so this one's new and has changed. Let's get it in your chart, right? So a lot of medical decision-making goes on based on what you're taking. And so even if you have that Safeway sack full of meds and it never gets opened, that's okay. But it'll be very useful if we need to answer a question. So I put in this one point, review any patient decision aids sent before the visit to increase efficiency. This is going to get bigger. We're still struggling here, not because of a lack of wanting this to work, but because we don't have the world's shiniest EMR. EMR stands for electronic medical record. Okay, you get what you can afford. Ours is okay. Back when I first started 11 years ago, our EMR was so terrible that within the first month I called someone from CU that I knew as a contact, and I'm like, I am afraid of this EMR. It's going to get me sued. It loses information, right? This is something we were a beta test site for an EMR called Dairyland, and poor Spanish speak struggled with that for quite a while. And I'm not taking. Yeah, they finally changed the name to Healthland. I was like, that being said, we ended up, long story short, starting conversations with the university, but later led to conversations with Parkview, and we ended up partnering with Parkview so that we could have an EMR that was reasonable. Since the university took over Parkview, we got kicked off of that, and we had to go purchase our own. So we're back into the initial position we were in, but we did a decent job. Like, we've got one that works. It has been a struggle because the company onboarded us during COVID when their company was having problems. We're still fixing those problems, but it is functional nonetheless. It has a patient portal that's reasonable. It's not the best, it's reasonable. But when we see patient decision aids, that's something we want to start working with to get the CMR to push information out, some questionnaires and things. You're coming in for a certain type of visit. How can I get information from you that you don't have to spend your time telling the provider before you get there, when you get there, right? You do it before in your own time, but then we're able to review that in an efficient manner, before you get there, so that you're not wasting time trying to explain it to us. And maybe you even spend some time getting your thoughts together, so it's more distilled by the time you kind of word vomit whatever came out, right? Instead of being more concise. So, let's see, we talked about that. So, at the visit start, if the provider doesn't basically set this up to get you to do so, please state your agenda early. So if they're not setting an agenda, and let me tell you, some days, like, providers are good to remember their own name halfway through the day because there's just so much going on. But as a patient, know that the beginning, the first down to business should be an agenda. Fair enough. Realistic number of concerns, I kind of mentioned. Sometimes it's only one. Sometimes it's up to 3. Some of my patients be like, wow, sometimes we talk about 5 things. It's like, yeah, but then the patient after you has been out waiting for 20 minutes. So, and just plan on being okay coming back multiple times. And maybe that should help you decide if you're on 10 medicines and you have, 20 diagnoses, don't pick that health insurance that doesn't cover your office visits at a decent cost, right? If you have to pay $50 every time you come to the doctor and you have a large number of medical problems and kind of run about 4 to 5 visits a year, then you have to put that money aside or find something cheap, find something that isn't as inexpensive. Because at the end of the day, don't let that end up being the barrier to saying, okay, no, we'll come back. Okay. Let's see. And in that collaboration at the beginning, being open to like prioritizing with your provider, right? If you be really rigid and not listening to them at all, why they might want to prioritize one thing over another, that could end up in a problem. So during the visit, medical decision making, right? That's what that provider's there to do for you. That's what they're trained to do. That's what they like to do. They want to help you with their medical knowledge. They don't want to spend 10 minutes talking about why your blood pressure medicine's $100 a month. Okay? If that is a real big concern and a barrier to your care, then they need to know about it. Let them try to help you with that, but it's not their job to go shopping for a medicine. It's their job to maybe choose a different medicine, right? That makes sense? Medical decision making, and to be good at it, you have to have the full story. So understanding that the story is important, but then we shift into options on how to investigate your problem, shift to options on how to treat that problem. And understanding those steps and stages along the way might mean that visit's you're not going to walk out knowing what's going on, right? You might actually walk out at least knowing where are we headed, what are we using to investigate your symptoms and your problems, but being okay with that we have to follow up and review those diagnostics to come up with what's going on and then determine a treatment. The third one's really, options, risks, benefits. I think I put that in there. The provider should be going over that with you. That's just like standard training. But if you're not hearing that, you need to speak up. It's, again, the complexity of what's going on in that provider's head, I think, bears mention. There's a lot going on. We're not 100%, we miss things. We forget to talk about maybe all the options for whatever reason. So you want to make sure as a patient that that's where the conversation goes if you're at that stage of, hey, we're talking about treatment now. And then the barriers, like I mentioned, cost, side effects, lifestyle factors, and that's, but when you think, if you distill a visit down, what is going on? It's like symptom, diagnosis, maybe diagnostics to get to that diagnosis, and medical decision making. Once you get to that point, you're talking about treatment. What are my options, risks, benefits, and why can't I do those things? Barriers. So anything that's kind of bolded there, I think, if you can keep that, that's the flow of a visit right there. And if it gets off in the weeds, and just try to help the provider center back in if you can. It'd be nice if both people know we're trying to center the conversation all the time. Proactive negotiation, okay, think of it that way. There's the problematic hand on the doorknob phenomenon, and that's you've got this provider with 2 or 3 medical problems circling in their head. They're trying to figure out how they're going to coordinate either diagnostics or treatment. And those things are in their RAM, it's in like their memory bank. And they're going to go out and act on that, and then you hit them at the doorknob and say, "Oh, I forgot to tell you," That's usually why I forget to get a referral. I have patients who sometimes I'm really good about it, trying to put my referrals and orders in when I'm with the patient. But sometimes there's a question I have to ask, like say my referral coordinator about the referral. Does this particular provider do this, and this, or should I be sending them to here because they live closer to this one? Driving to Springs is kind of difficult, but does this one in Pueblo do that? I have to ask those kind of questions, right? And then you hit me at the doorknob, and we just go down some other rabbit hole, and then I come back out, and I was like, oh man, really, So that happens a lot. There's a lot stored in the temporary memory banks that can get wiped with a question. So effective agenda setting at the visit's beginning, or I should keep saying that, sorry. These are all headings of the same thing. So focus on the medical. Again, we talked about small talk, but diagnosis, treatment, direct, complete. The symptom tracker, there are some actual handouts that are symptom trackers for patients, but you don't really need something that formal. You just need to be able to describe your symptoms, when they occurred, what do they feel like, how long, are they every day, only some days, how severe, those kind of things. And however you can concisely describe those really helps. And to imagine if you've never discussed this symptom with someone else, maybe it's something really private, or maybe you've just been so concerned about it, it's actually difficult for you emotionally to talk about it because you're worried about your health. That can go sideways on you really quick when you're voicing it for the very first time, right? You're talking about something that's scaring you. Hopefully the provider is able to guide you in describing those symptoms in a way that makes sense to them medically. But for you, maybe you're just really focused on one part of the symptom that maybe not that medically important, but has you most concerned. Sometimes it's easier to take a breath, or even before you go to the visit, have a symptom tracker. You're writing it down, you're putting it in your own words, reading it, and going like, oh boy, I don't want to spend so much time talking about that. I need to, that recentering of how you describe the problem can really make the visit more efficient. It can mean the difference between 20 minutes describing one medical problem and getting it all out in 5 minutes, having a good question and answer time with the provider afterwards, where they're asking you meaningful questions, as opposed to just having listened to you for 20 minutes and trying to put it together, right? And they should be, we're all trained in how to sort of especially if things are emotional, hey, I hear you. I just don't want to spend too much time in this one area of this problem because I'm afraid I'm not going to get it all during this visit, and I really need to. Hopefully you're hearing language like that with your provider, where they're kind of honing in on the things that medically matter, but not dismissing the experience for you. That's the hard part. That's a challenge. So, especially in 15 minutes, right? Let's see. All right, I have a long list of references here. There was actually an article, The Hand on the Doorknob, which was, I saw that and I was like, really? Yeah, that's an awesome title. So we can open this up for discussion. Topics I had kind of thought that go along with this. The provider's a human being. Man, a day in the life of a medical provider can be pretty intense. And I'd say one of the more difficult things is trying to stay focused on the experience of the patient. Because someone could be earlier I joked about someone can come in incredibly focused on their toenail fungus, and then the next patient has had fecal and urinary incontinence for 3 months and it wasn't a big deal. How weird is that? You know what I mean? And that is my life, when I come to work, and it's, there's this mix of the high-risk medical problems that maybe people don't really grasp they're high risk, and low-risk medical problems that just rule and ruin somebody's life, right? They're both equally important. And then the other thing is my set of values and what I think is important for a patient in their medical care in their life may be totally incongruent with what they have experiencing, right? And so trying to figure that out is tough. We try to key into people's emotions and how they describe things, but something may be intensely alarming to me that I'm hearing them say, and they're just nonchalant. No, I don't want to talk about that today. And you're just how do you not freak them out? But at the same time, if someone is there might be something that is very low risk, but just has been on their mind for months, and they finally had the courage to come talk to you about it. So your provider's dealing with that mix of stuff all day long, and it's just rapid fire. So yeah.
I have a question.
Yep.
About current internet and people getting information.
I was gonna talk about that today, yeah.
Okay,
Like-
because that, what kind of a challenge?
So I had a
is
couple of
that?
slides, I had a couple of slides devoted to that, but I got rid of
Oh,
them.
okay.
You know,
If it's not relevant.
no, this is very relevant. I'll try to, so your provider, by the time they get trained and they're practicing, they have pretty much made it nearly impossible to not be objective. Like, my brain does not work subjectively anymore. Like, we're truly scientists at heart. We're trained in science. We spend so much time with data, objective data, and learning if it's good or bad. Like, that's a huge portion of medical school, is looking at studies, and they're like, does this study actually show you what you want to know in a way that proves it, in a way that, you know, is meaningful and that the data is good? Or is this junk data? So we're very good at parsing out what to pay attention to, you know, the bullshit detector, right? Very strong, right? So, but that being said, we live in a time where I cannot compete. My 15 minutes with you cannot compete with the 100 hours you spent on Facebook. Not even close. It just can't. And I have no way of convincing you. And I would say that the internet can be this amazing source of information for patients. There's some really high-level, free information out there for patients that is excellent. That's not where people spend their time most of the time. And I don't blame them for it. I have an Instagram account. Like, I can't believe this stuff. I'll be watching something and my blood pressure will go through the roof. I'm like, wait a second, this isn't even real, you know? And it'll be something that's medical. I mean, I think Instagram knows I'm a doctor. And it finds that niche of things that'll set me off. And I'm like, I can't believe it, you know? You know, like, no way. And then you look it up and it's like, you know? But patients deal with that without that objective training, right? It's almost like a religion to me. I spent so much time learning how to tell the difference between something that's not real and real, and I can be fooled. Now I know where to go look as soon as I start getting riled up. But that being said, patients come in with questions that are way off the mark too, so that's tough. And I'll segue into the patient portal with this one because, you know, imagine going to your mechanic and saying, you know what, I found out, and tell me what you think about this doc, or mechanic, whatever. If I paint my car red, it gets way better gas mileage. And you're just like, okay, where'd you hear about that? And you know, you're trying to be respectful. But you know, and welcome to like my experience of supplement market. We're the most, if you're my patient, you've heard me say this, we're the most like highly influenced and deepest pocketed nation in the world when it comes to the supplement market, which has zero regulation. I could make something in an old oil barrel in my garage and mix it up and sell it, put in a pill, and nobody's going to check it for its purity, safety, whatever, because there's no way that anybody can afford to do that. Okay? So most supplement companies probably mean well by all means, and a lot of them are probably very reputable and do a decent job, but at the end of the day, like as a physician, I don't have the, I have to tell my patient, sorry, you know, unless it has a USP stamp on it, right? US Pharmacopoeia is a place that tests very simple things like vitamins, you know, but if you have a supplement that has 50 ingredients from 20 different sources around the world, I guarantee you there's heavy metals in there, right? It's like, how could there not be? You know, the safety goes way down. But like when there's something like turmeric with a USP stamp on it, you can stand behind that if you want to take it, you know, whether or not it's going to help you medically, you know, but at the end of the day, and so people come with these really intense questions I have zero training on, you know, like, I can look things up with them now. There's a couple things, and I'm going to segue patient portal and into like how AI is helping increase face-to-face time. But I can pop things into an AI software to ask medical questions that I have no clue on, to see if there's any true evidence on, say, like a supplement or just a bizarre medical question a patient has, as opposed to trying to Google it or looking for a source that's reputable and spending half an hour answering a question that probably doesn't matter.
So you're saying that the medical, you have access to a specific AI program
Yes.
that is meant for medical professionals?
Yes, and I can talk to you guys about it in a little bit. those kind of questions I really appreciate my patients presenting through the patient portal instead of their visits. Because their visits are not really intended to be a bizarre random medical question on something that they just heard about Facebook and like, no, we're here to get down to brass tacks, look at your meds, maybe whatever it is you're there, I mean, whatever your medical problem is, you know, look at any diagnostics that are meaningful and interpret those and make a medical decision that I'm trained to make. If there's a patient portal question that comes in about something random, I always do my best to answer it. And I really appreciate the patient portal because I can do that in a way that's meaningful to me too. I can look at what this paragraph of question, what are they really trying to ask me? And I have no idea what that's about. And I can pop it into the current resource I use and love is called Open Evidence. And it takes literally, this is the most insane thing, and I can't believe we have available now, the New England Journal of Medicine, the American, everything AAFP ever wrote, every major organization and guideline that ever came out in the United States, all just dumped in for the last who knows how many decades, and allows an AI computer to go after it and ask questions of these medical resources that only publish in their journals if it's good data, right? Since that became available to me, my abilities in medical practice has gone through the roof. I learn things every single day that blow my mind. And like statistically significant too. Like I can be like, I've got a patient in the hospital right now and I can describe what's going on and you know, these are my concerns for their source of infection, but I don't have one. I haven't been able to grow the bacteria that's causing them to be sick. And I'm trying to decide between these two sets of antibiotics, knowing that this set over here causes these risks to the patient and these don't. What's the additional coverage or benefit I might get? And it might give me a number and say like, well, odds are your coverage is going to be increased by 3%, but look at all the kidney risks you're going to entertain by doing that. Okay, cool, clear benefit, right? Of not doing it. I'm not going to make the switch. Before, looking up something like that is impossible. And there's no way I have the time to even come up with, you know, that'd be something that could ask a medical student to spend a day trying to figure out. And we make decisions like that all the time, where it's like, if I knew the percent risk of this compared to the percent risk of doing or not doing something, there's a clear decision, but like finding that information, it's either up here or it's not, right? And to be able to search every meaningful journal article that ever existed in the world and have it produce information and then provide you with that journal article, it's amazing. Like
first of all, thank you for being here, Dr. Dutton, I appreciate it so much. The patient portal for me has become the best way to communicate with my provider, for sure. Because I'll come up with something after a visit that I totally forgot to mention, and when they have time, they can answer me, which is great.
Yep.
But is this happening all over the country? Is this just us? Is this Colorado? Or is this how our healthcare truly is in this country?
When I was doing this presentation, I was using statistics, countrywide statistics. So these are from like United States medical practices, right?
Okay.
These are journal articles written on the United States. That being said, parsing out Huerfano County's experience compared to, right? Our payer mix is unlike any other, unless you're in a poor county. I mean, we're mainly Medicare, Medicaid, and those payer mixes, for instance, and Dr. Clough, you know, God rest his soul, right? Love that guy. He got punished by this exact situation, right? That's a guy who wouldn't have turned anybody down because of their insurance. He probably didn't even look at the insurance when they walked in the door. You know, like reimbursement was not his primary concern. He was a doctor, and he cared for his patients deeply. He couldn't make ends meet. He lost his clinic because of the system. Because the majority of payers here are Medicare and Medicaid, and you have to argue, compete, and struggle for those dollars, and typically get reimbursements that don't even cover the cost of the care in a private. You know, he was a private medical clinic. It would have taken him 10 people to do the appropriate amount of billing and arguing and all the stuff that would have to happen in order to even make ends meet. And I personally looked at this. At one point in time, I was looking at it, not, you know, the hospital was kind of unstable, and this is right before COVID really flourished, really hit hard. And that answered my question of what do I do? I stuck with the hospital because I wanted, you know, I care about that hospital system a lot. It was like if things did fold, you know, and I wanted to live here and still raise a family here, I'd have to be a private doctor. And I looked into that. It's not totally impossible, but it would be an experiment by all means. You'd have to go into it being ready to lose your butt. And
So basically you're saying this is what every doctor and provider, whether we're here or in Denver or any other
it's a
part,
different flavor. So pretend I work in Denver for Kaiser.
right?
I walk in and I say, well, this is kind of what I want my practice to look like, blah, 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 and they'll laugh at you. What do you mean? This is the practice you get. You work for Kaiser. Every single doctor has the exact same financial agreement. You will see the exact same number of patients as your buddy, and you will practice medicine like we tell you to, right? They're a stable system, and they've done pretty well over the years, but they're struggling a little bit too. Versus if you go to private practice in the middle, let's find a bougie practice in the middle of Denver Springs, they will say, listen, we know, we've done the business model, I have a financial advisor, and I can only take 20% Medicaid before I start losing so much money and so they'll have like a panel of Medicaid patients. And when they hit the max number, their panel, they don't accept any more Medicaid, and you might show up to their office, listen, we can put you on a list of people when we have another Medicaid opening, we'll add you to our panel. But if you show up with, I'm trying to think who's like a really good insurer, what is it really? I don't know, I'm blanking. There's a few that are well known to be reasonable reimbursement. So they just fill their panel with as many of these, and these are like more private healthcare plans that you get through an employer, and then you look at, with the Affordable Care Act and what's happened to Medicare. If you think about it, take Medicare and the government says, okay guys, you have to offer all these main things of Medicare, but then do whatever you want. That whatever you want kind of looks different for every provider of these Medicare Advantage plans after you hit 65 and you qualify for those. But some outstanding things I see, it's like you come in with almost any Medicare Advantage plan to the hospital and you've had a really rough year. On day 29, if you're in a Medicare Advantage plan, someone's going to walk up to you and say, hey, so your insurance runs out tomorrow on the hospitalization, you'll be responsible for a certain amount of your hospital bill after that. If you're on traditional Medicare, you get 100 days a year. But nobody knows that when they go for this traditional Medicare Advantage plan. They do know that they got silver sneakers. Yeah, they gave me silver sneakers. Well, they're waving all these other carrots in front of these people, and not to say that certain Medicare Advantage plans wouldn't work for a specific patient, but there's no one out there who's a specialist on all this stuff who could tell you, hey, let me hear about your medical problems. There's no doctors anyways. Like, doctors don't know the plans at all, other than what we have to fight. Everything I learn about what isn't covered is because I'm fighting it. But there's not like, you go to an insurance agent, they're not a doctor. So not only your medical problems and your medications, they'd be like, oh yeah, you know what, United, whatever Medicare Advantage is for you, because that's going to be the cheapest way to go because of this medicine here. There's just no way. Versus traditional Medicare and Part D, it's very difficult to navigate as a patient, and I don't think anybody has a great answer to that. And that's.
I think it's deliberate that people are not educated. There's no process to educate people about their health care under Medicare, Medicaid. It's just kind of random.
On my end, it almost seems more like an experiment.
Yeah.
With a for-profit experiment. And
They don't want you to know. And in my opinion, there is a deliberate attempt to keep people, individuals, from knowing what's ahead for them in different scenarios.
in my experience, at least, it's not as much as deliberate as just thinking of connecting those two dots. It's irresponsible to not have a role to connect those two dots for patients.
That's a
And there's
great
not
word.
really, so it'd be like, you'd have to have someone with almost a doctor's level experience, maybe at least an RN. And we have those people, but they're not usually involved in the insurance world. We call those care coordinators, right? My favorite role in the entire healthcare system is the care coordinator. And it's usually an RN or an LCSW trained person who is taking all the slack out of the system that they can for the patient, right? We just got one hired, finally. I've been trying over a year. And she'll be starting in January for the clinic. But
Thank you.
it's awesome. I am so excited. But
Well, basically, all I want to do is thank you for caring and for telling us about what you've given us today and trying to stick with the system, because I don't know how you guys do it. We're all struggling out here trying to get good health care, but you guys are in there dying too.
it's, on the primary care end, it's very challenging all the time. There are certain roles in the clinic that are behind the scenes that nobody knows about that are super important, okay? Our referral coordinator, Ellen Behill, okay?
She's incredible.
What she has to do is unimaginable, because like she has a Rolodex of every referral she's ever sent and anyone's ever sent out of our clinic, all the way up the Front Range. And she's matching those referral sources with what the provider's asking. And she's not a medical person, right? She is now. I mean, you learn the school of hard knocks, right? But like, we've got this patient problem that's well beyond our capability, and then we're trying to find, we're trying to coordinate transportation, timing. Like, this referral is where I want them to go, but they're 7 months out. This one will take them, they're 2 months out. This one's 200 miles away. This one's in Pueblo. It's like, and so Ellen's balancing all that. And like in a typical clinic day, she might get 50 plus referrals. And there's one of her, we finally hired, she has someone helping her now. But like, Ellen has been the person the whole time. And so, I mean, what a challenging role without a lot of pats on the back, right? The care coordinator will be another one of those. That care coordinator is the person, rubber meets the road. Why did you not get to your appointment? Or why can't this person get this care? Why can't we get this diagnostic? What happened? To the point of like, I didn't understand the paperwork. Come on in, I'll fill it out for you. That'll be that person.
Fabulous.
I couldn't coordinate my med ride, Like just all these things we do, we go to all this trouble, and then the care doesn't happen because it's something that has nothing medical going on at all. When whatever happened, I don't even pretend to understand what happened with the med ride thing for a little while. Holy crap! You know how many people couldn't get care in like a 5-day time span? It just like, it was this massive pile up of medical care, and then that all that slack to take out is all extra time you don't have, and so. And it's, I mean, I'm sure I'm painting like a doom and gloom situation. It's not. Like, I'm very proud to work for Spanish Peaks. The people at Spanish Peaks, I have big hearts and they honest to God care. Like they work so hard. Outpatient, inpatient, there's so many extra hours spent, I don't know, it's, and I wouldn't be there if it weren't for that. I mean, definitely have been struggles. We've had some definite bad apples in the past. They're no longer there. Like I've had a couple people who come and go in Spanish Peaks have, left a bad mark, but we end up getting rid of them when that happens. But again, that's what happens when you have a place where you sometimes struggle to find people to fill all the roles. It's hard to make sure you find and maintain people that are qualified and are there for the right reasons. And like right now the team is excellent. Like I've been really happy lately. So, but yeah, I don't know.
Do you see the future of healthcare becoming centralized so the insurance issues don't continue to cause problems?
I'm more concerned it's going to break first, and then we'll have to come
And
out.
then we'll
We're going
have
to
to-
come out of the rubble of that, and I don't know what that's going to look like. I don't, who knows? I mean, there's obviously there's all this stuff going on politically with how people are going to pay for their care. and, you know, to the point of a government shutdown, right? And, I mean, again, I'm more as a physician, I'm more on the side of what you hear coming out of Bernie Sanders' mouth. You know, I hear that guy talk, I'm just like, oh, please, you know, nobody's interested in that guy. They're just like,
Because there's no money in it.
there's no money in it, and American care has morphed into the most expensive thing we have. I mean, most expensive system, worst care delivery.
Why can't they see that?
I think there's enough people have their hands in that pot now that are so powerful, they're not gonna pull their hand back out. And they're gonna break it before, and then that will be one of the most costly events in American medical history, I'm sure. You know, like, when that, if it does, I mean, again, I'm hoping it doesn't, but I'm worried for it, especially, it's not gonna break across the spectrum, but I think in places like where we live, high risk of breaking, you know? And I don't know, we had, Kay and I had NPR come and interview us a while back. This has been quite a while. And I thought it was a really great interview, but they didn't put any of it out there. So I spent like an hour with them, and nothing came of it except for a picture on the webpage. But like, they asked a lot of really thought-provoking questions. But and again, I think we might have been kind of an afterthought interview. And Kay, they list, you know, Kay was on the radio a little bit, but none of the stuff I talked about. But it's hard not to get a little political on it, you know, just because you see it impacting patients. But like, I think on our end, my slant of that experience is much different than someone in Denver, let's say, because my patients are mostly Medicare, Medicaid, and they're always complaining about their access to care, and that might be medication related, that might be diagnostics and how much it's going to cost them. You know, it might be, you know, I had someone just really needed an echocardiogram. Like, we really needed to see what was going on with their heart, and they got it all lined up, and through their cardiologist at Parkview, and they got a call like the week before that was going to cost them an extra $600, and they called it a maintenance fee or something like that, and the patient's like, you know, go to hell, I'm not doing this. Like, it was, and their impression of it was that it was a cleaning fee for the room. And I'm like, I'm positive that's not what's going on, right? And so our care coordinator reaches out, and it was their insurance. Like, they have this copay, and it was explained to them, and I don't know if that's coming from Parkview or their insurance or whatever. It was like a maintenance fee or something. And so he heard maintenance and thought it was a cleaning fee for the room.
Wow.
The Parkview was going to charge him, right? No, it's the cheap insurance plan you selected, and it says right here, like, you have a copay for things like echocardiograms. It's probably more than the cost of the test, right? Echocardiogram doesn't cost $600 to perform. I mean, like, the cost to the provider of that care, right? The person who performs it, and then, you know, maybe by the time you have a cardiologist read it, but, you know, like, that proportion of that copay is, that's like, dang, you know? I would expect that kind of a copay for someone getting an MRI or something like a really expensive test. An echo is an ultrasound, right? And so, but you get to the end of that, and you've got to tell the patient, man, you kind of picked the wrong plan.
So from your experience, what's the best insurance company to deal with?
I mean, when it comes to Medicare, and this is not a promise you don't, this is unsolicited, right? Probably Medicare traditional, because there's no one else putting their hand in the pot, but I mean, that's just,
What about private?
that's me being a hospitalist too, huh?
Private. We're not Medicare age yet.
You know, I can only speak towards my personal experiences, and so far I haven't had a good one. You know, we used to be Cigna, now we're United at the hospital. I mean, I'm a human being too, I have really shitty insurance, so it's like, I complain about it, you know, but it's like, I don't think there's, I don't know, man, I haven't really, I was trying to think of who I was trying to think of last time, the insurance company I argue with less. I argue the most with Humana.
And I understand that Kaiser is like a county provider, and all of the county.
Yeah, right, for here, and like Kaiser doesn't even exist here, right?
Exactly, so, and they have, everybody has to go someplace else.
That has been the case for 20 years. So when I was in residency, that was the insurance that they gave us as residents. And one of my main reasons for choosing St. Joe's, other than they were an awesome program, is they gave me health insurance because I couldn't afford it. Like, I otherwise could not afford to pay out of pocket, and some of the residencies don't cover your health insurance, even though you're training to be a doctor, right? So I was like, whatever, it's Kaiser, cool. I ended up with a blood clot during my residency, right? And I was on a rotation in Lahana. And they're like, so I was on Coumadin because they wouldn't pay for any of the new anticoagulants. So because I'm on Coumadin, I got to go and get my INR pretty frequently.
Oh,
They wouldn't pay. Kaiser doesn't pay for labs outside of their network. $50 a pop to get my blood drawn. By the way, I'm a lab tech. Like, really? So I'm like, and I called the residency. I was like, hey, by the way, once a week I'm gonna miss a half a day of training to drive up to Pueblo to get my INR because I'm not doing this. Principal, you know, if Kaiser wants to pay for that lab draw, which I know costs the lab about $5 to do, and they want to charge me $50 for being out of network, I'm gonna drive to Pueblo and get it for free. And that's what I did. I took a half a day off and went. The training wasn't that good in the Honda. Like, it didn't bother me. Like, it was like, but like, it was on principle alone. I'm like, I'm not doing that. I used to draw labs and run them for a living. I'm not going to pay $50 for an INR for treatment while I'm training in a low income area, right? So, and Kaiser did not back off of that. You know, I called them and told them I'm a physician resident down in Lahana, and you guys are trying to charge me $50. And it's like, it would have been, and for a resident, this is a lot of money, probably been like $500 to $1,000 by the time the rotation, no, it wouldn't be that much. Initially though, I had to have them a couple times a week, so it's hundreds of dollars, right? Not a big deal compared to like some of the patients here who just like can't afford the care and buy groceries too. Fixed incomes are everywhere in Northfield County, and so as a physician, I probably spend just as much time making medication choices based on what someone can actually afford. Or even like just stupid things. Like Northfield County for some reason has a large number of people with low sodium. And like one of the treatments is a very inexpensive low sodium, right? Hyponatremia, right? We do have a lot of alcoholism in our community, but like that's part of what's driving it. But there are plenty of people that have, are not having problems with alcohol that have low sodium for some reason. I can't explain it. I literally went to the lab one day. I'm like, I think the sodiums could be off, and it's like, but they're not. So one of the treatments is something called urea, okay, and it's not even a pharmaceutical. It's a supplement. There's only one company in the U.S. that makes urea, and it's super expensive, and it's like the cheapest thing to make. But like, and it's one of the easiest ways of treating the problem. And but multiple patients, it's one of these medicines. It's just expensive enough that maybe I can handle it. Maybe I can take the cost, but it's this wide dose range. And you get to the point where it starts helping them, and they're like, I'm sorry, it's just reached my threshold. That's just too much. It's like half of my rent. And you're like, and it kills you because it's a monopoly on a substance that is easy to make, but an insurance company, I've tried to talk with an insurance company on this particular item, they won't cover urea because it's not a pharmaceutical. Even though it's like, you can go to any guideline-based therapy, it's like one of the 3 major treatments. It's one of the safest. So, I don't know, just stuff like that all the time, and you're just like, man, this is really screwed up. But on the end, bringing it back to why we're here on this talk is like, that face-to-face time should be coveted. It needs to have, I think in the patient's mind, if it could have like a special, when you enter that room, kind of hold it in some regard, and not just a hanging out talking situation. Hold it in a high regard of what it's intended to do, know that there's a purpose for it, it's medical decision making, and how do you get to that point the easiest, but still connect with your provider. That's a challenge in 20 minutes.
So, question, are you supervised in any way regarding the time used? And are there any punishments or, I mean, how do they deal?
So yeah, me personally, no, I'm the
No, I'm
medical
just
director.
saying. No,
No, I
but
get your
I'm
question,
saying,
yeah,
you know,
100%.
what happens administratively? Do they come after you? What,
So,
I mean, what's the
no,
ramifications?
your patients end up being the ones coming after you, because when you run late in clinic, people wait, and they hate to wait. And so that's the main form of punishment. That's punishment one, day of, and we get, it is, I mean, when you consider how many visits a provider does in a year, and then does over the course of a decade, it starts to become like, almost like PTSD. Like, when you hit the half an hour mark behind, like, your blood pressure goes to the roof, and you get super, just, it's really hard to concentrate. And your medical assistant starts to get really out of shape with you, because the whole team starts to fall apart at 30 minutes. Like, if you're getting a half an hour behind, every patient's getting upset, like, nothing's working nice. And in the flow of how the patient flows through the clinic from front desk to medical assistant to provider, maybe back to medical assistant, back to provider, maybe to the lab or whatever's going on, that breaks apart pretty bad at a half an hour. Like, things really get discoordinated.
So it's not just you, it's the whole system.
Well, yeah, so that flow, because it's based on efficiency, isn't made to work outside of this, 30-minute late thing. And so, and then you just kind of like cut your losses and start blasting through your day, not doing any documentation. So on the day you get 30 minutes behind, you're gonna have a 4-hour experience when you get home. If that makes sense. If you get behind in the morning. So if it's really bad, your second patient of the day is just a complete train wreck, and they need an hour and a half of your time because Parkview did a really sloppy discharge, and you don't even get lunch, like, not only will that be one of the hardest days of your week, you get to go home to another 4 hours of work or something. So like, it falls apart rapidly and gets completely out of shape. And then to further answer the question, the second end is me talking with the provider because they're not getting notes closed. You got providers, or you got patients calling in on orders they were supposed to put in, they didn't. Because the complexity of that day just overwhelmed them to the point of, they hit their bandwidth. And it's interesting because as a provider, if you can maintain your bandwidth in like the 50 to 75% range of computing up here, you do pretty good. Once you get beyond that, you get in the 90% range, it all falls apart up here too. Like, you just can't keep it all together. It's like trying to juggle. If you're a professional juggler and you can do 4 or 5 balls, when someone throws a 6th one, it's just like, try again, try again, right? And so, that pressure creates moral injury, because like, we're here for patient care, for crying out loud. I just want to deliver good care to people, and you want me to do all this other stuff. So we have a couple providers who are just excellent providers, and the reason they're excellent is because they care so much. They're just constantly punished. I was one of them for a long time. I mean, you guys know, like, I don't spend that much time in the clinic anymore. The hospitals needed me more over the years. Like, I've shifted my practice to more than 50% hospital. Not on purpose necessarily. I'm not like guiding, like, that's where I spend my time because I really enjoy my clinic days. Just in that situation, I have noticed my stress coming so much further down because of the juggling act is not as intense. But I pay for it with time. I spend way more time at the facility than I would have. And because I'm in the hospital 24/7, I don't live there for a week, but my days are long and I'm on the phone all the time, and a lot of times I'm going back in, and so there's this trade-off. And then I'm the medical director of the clinic. That has taken a lot of my time too, but I would never guess how much time I spend on this whole efficiency cycle stuff. Boring. Ugh. Like, I hate it, but it is what it is, and the computer, I need, before everybody's like starting to leave or anything, but when I talked about AI, the one thing, the technology that I've really embraced, that I mean, everybody has. Right now we have a technology, it's called Heidi AI, okay?
What?
Heidi, it's cute, Heidi.
Like the name Heidi?
I think it's, yes, Heidi, H-E-I-D-I, Heidi AI. And Heidi was designed in Australia, if I remember right, by a physician. And so starting at about 3 to 4 years ago, AI started getting powerful enough to start ambient documentation of visits for doctors. but wasn't that great. And of course, all the big companies. So we always used a dictation software, which is not AI. It's just literally it's like when you talk into your phone. So we used something called Dragon, and Dragon was owned by a company called Nuance. And Dragon was probably the best product at the time. It could run on your cell phone. It could run on your computer. It didn't listen ambiently and write things down. You had to dictate into it, and it would like word for word whatever you say, comma, period, exclamation point, you know. It was like 80% efficient, or 80%, sorry, accurate, and then you're going back and typing and clunky, but save time because you're not typing. Anybody can talk faster than they can type most of the time. So we used that for years, and then AI got to the point where we could ambiently listen to a conversation, pick out the different voices, and create a dialogue like a book. Okay, so that's layer one. Layer two is I'm learning how you speak. I'm learning your voice. I know you don't like the word Lasix and would much prefer furosemide, right? Whatever, right? Layer two, right? And then layer three, I'm hearing you medically what you're saying, and I have the most recent guideline-based therapy to offer you on the side of your visit so that you're prescribing the right medicine to your patient. Take a look at this. I'm not telling you what to do, but that's not here yet. That's layer three. It'll probably be here this year. It's costly, right? But so when that market got established, it immediately flooded at Microsoft's like, I want a piece, you know. So they went and bought Dragon and turned it in, and they turned it into something called DAX. They came and presented DAX to us, and it was so big brother, we're all just like, not interested, you know. Super expensive, but like, it was like, Dr. Mike's like, so what do you do with the recordings? Because they said, we record you, and then it, you know, what do you do with the recordings? Oh, well, we de-identify them and use them for, you know, what, and he's like, and then Jocelyn's like, for learning how to be a provider and taking our jobs in 5 years, and we're just like, you know, like that's kind of where we're like, and it just didn't, it just didn't meet, like, well, number one, it was too expensive, but number two, just not something we would consider using. Then along comes Heidi, which is like, built by a doctor. We don't record you. We literally create a transcript real time, and from that transcript, when you ask the computer to do something with that transcript, we do it, and then it goes away.
Wow.
And really? How much does that cost? And they're like, it's free.
Wow.
Because we're using you to kind of help design the software. And it's in there, you know, the initial product is free, and you can use it one visit at a time. And you have to get rid of it and then go to the next one, and that's really clunky. But if you want to pay for it, totally affordable. Like, it's like $75 a month or something. Right? It's just like, huh? Really? And it is. It's been, Jocelyn and I first started using it, and then it was outstanding. Like, it's like, I can set in and, you know, I don't close this because my microphone's there, but I'll set it to the side and do this with my patient now. And I might look something up, I might order something, but now the computer is not my primary. And I walk out of the visit, and actually nowadays, the thing is I can design my own approach to the notes, so I can have all my patient note documents better than I can do. Seriously, I can't type out a note that caught everything and not be as wordy as me, you know? And then at the end, my patient instructions is the most important thing. It knocks out these patient instructions that are just like to the T. I have a couple of little changes, and I can have that to the front desk and printed by the time you get up and check out.
That's
Wow.
awesome.
It's
And
like,
you're done.
and well, very close to being done, 5 minutes from being done. That note is written. I can go out, I have to copy and paste, and this is the Heidi thing. Like, Heidi is not integrated into your EMR, right? They're working on it though. I still have to put in orders. I still have to fight the referrals. I still have to do all that stuff. But the documentation's off the plate, and that was the biggest time suck of everyone, right? It literally, and I can say without a doubt, saves me more than 2 hours a day.
That's
Wow.
awesome.
And that's the time I was spending at home. The kids are playing. And I'm like sitting there, you know. That's awesome. And it's very inexpensive for what it provides me. I would pay for it out of pocket if Spanish Peaks wasn't going to pay for it, whatever. You know, it's not that expensive. The amount of time it saves me. they do pay for it. And so every provider got on that was willing to embrace it, and every single one of them, like Mike Mall had an I Love Heidi shirt made. Because we're all just, there's that.
Thank you, doctor.
No problem. We're trialing a different type of software called Avo right now, which is the layer 3. But I think they pushed the product out before it was ready. And so I did 1 week with it last week. It cost me so much time, I quit using it after a while. But it's supposed to add that third layer of, and it basically takes the information that Open Evidence is. So Open Evidence is a separate resource on the side. Let me share it with you guys real quick. It's just, and you do need to be a physician. No, actually, you don't need to be a physician to use this, and they have they have a patient version of this, I think. If I write in give me,
What company created it, you know?
I'd say we don't have to be a physician to use this software.
I think there's a non-physician version of this.
So it's got everybody on there, wow.
Did you see that?
Yeah.
These are just some of the major ones.
Fabulous, yeah.
Okay. So this is a basic.
Look at the team. It's just, you got like PhDs, engineers. So either way, it's kind of what it looks like. I can ask it a medical question. If you didn't have Heidi, it's a free resource. If you didn't have Heidi, it'll actually assist with notation in different ways. It's just really crazy. A buddy that worked at Denver Health told me about it about a year ago, I think. And I was like, no, I've never heard of it. I was like, dude, you need to check this out, right? It's like, and the first day I used it, I'm like, this can't be real.
Wow.
And then like the live links directly to a medical journal article that I don't have to like pay for. I don't even know where this comes from or how it's possible, right? It's this massive and then I have a medical student most of the time. I take medical students from the University of Colorado, and they'll come down and spend 2 or 3 months with me. Like, it would be irresponsible for me to try to answer some of the questions they ask without just, and I share that with them. Like, I'd be there, like, tell me something about this medicine, and I'll be looking at it and be like, yeah, I was going to tell you this, but this, and this too. And so, I think in the next year that there's going to be some pressure come off providers. I'm sure will be felt by the patients too, because there's these assistive devices that are that are really good tools that we just always really needed, never had. The previous resource that the most doctors and providers use is UpToDate, it's called. Well known, been around for a couple decades, and it would take the resources, but they were, you would pose questions, and if it didn't have that resource, they had a team of doctors basically and scientists looking and see what questions get asked the most by doctors and try to answer them and write a summary article that might be, their articles range 30 to 100 pages long.
Wow.
Right? Super intense level of information, but here's your article, here's a summary of what's going on. Are you looking for any of this? I don't know if you want to search the article, here's your search bar, right? The information was there, but it was in a read format that was not ask a specific question or pose a specific question that, that gets answered with an AI-generated answer that provides backup with evidence. And it's pretty cool. I gotta say, being a family physician trained in outpatient medicine and the hospital in 3 years' time, right? When you go to residency to be a family doc, it's only 3 years. And by the way, on the side, learn how to deliver babies and take care of, do obstetrical work too, right? So you're spreading yourself very thin. You know a little about a lot. And the goal of that training is to know what you don't know and be able to look it up really rapidly when you don't know it. It happens every day. Versus I am a dermatologist is a great example. Dermatology is like this incredibly well paid for like laser beam of spectrum of medical care. We practice dermatology in family practice, but if you get anywhere outside of our scope of practice, because I've only seen that rash twice in my lifetime, you know, I have someone to refer to, but I think with these tools, it makes us much more powerful as family practice docs. Because now I can look something up and probably give you an answer in the room that I would have had to go home and look up and spend 20 minutes even coming close. Or I can be completely stumped about these 5 symptoms that all occurred in the same week and literally span every system of your body, and I really can't put this together. I can pop that in there and at least get a differential and go, oh gosh, I didn't think of that, you know. Right. So,
And hopefully will attract more people to primary care.
when these medical students come now, I'm like, man, it was just me and Mike Mall when I started.
Yeah.
He was my colleague. I had a lot of trust in him though. Like I trained with him when I came down, and like, well, let me tell you, coming to a small town as a new doc, you know, with only what you could fit in here in 3 years, it's like, it's nerve-wracking. And having Mike and Lori, actually both of them were, you know, I was so much more likely to come here with them as colleagues, and they're both of them are insanely smart. I mean, Mike was in like AOA, which is like the family medicine doctors are usually in AOA too, but it's like the educational fraternity of, you know, he's got a lot stored up in his brain, and he really appreciates and enjoys medicine. He's always learning, and so perfect provider to have been my colleague when I showed up, and got me off the ground big time, you know. But yeah, nowadays, like, I think this will be a crutch to help new doctors go in without being overwhelmed. I mean, because it takes some guts to leave a residency and just go straight to a rural community. I mean, most docs, I think, they think, well, I'm going to stay in this. A lot of docs will stay in the city and just practice and get really comfortable, get a decade under their belt, and then decide maybe they're going to go somewhere rural. And that happens occasionally, but most of the time they get too comfortable and they don't ever do it. And a lot of the people in my residency would have enjoyed a rural practice, but maybe just didn't have, you know, the guts to go for it. You know, it's like, chutzpah, yeah, you're right. No, but it's, these resources, I think, will, you know, I never formally thought of it that way, but I do talk with medical students, like, man, you're just so lucky. Like, now this is such a cool resource in your training. And it'll be also like, there's kind of this like part of training where you get pimped all the time, right? You have to just attending asking you these bizarre questions you can never answer, and they're always coming down, and you're like, it's like maybe that'll be less of a thing, and it'll be more about like what really matters, like what are you actually going to see, and then not worry about the zebras, you know, like if something's 1 out of a million, like why are we focusing so much training on that? That shouldn't be a test question when you're trying to study for your boards, right? So, yeah.
Great.
Cool, well,
Cool.
thanks
Thank you
for
so
coming,
much.
everybody. If you guys want, I really wouldn't mind coming quarterly. If you guys have topics you can share with the library that you want to hear about, it could be any medical topic, or, you know, it doesn't matter. More than happy to prepare a talk and talk about it. So.
I think you're really helpful. You're really accessible and clear in presenting, and that's